I call upon to stage Dr. Thomas George, who is the senior glaucoma consultant at Chaitanya Eye Hospital. When we see that many a times we get our colleague feels that isn't the cornea slightly larger than normal, so we always doubt whether this child would have a congenital glaucoma. Over to you, sir.
Thank you, Anita. Good afternoon. Uh, when one sees a cornea as being too large clinically, the real suspicion we have is the dangerous one, that's glaucoma. This we go for the symptoms in a congenital glaucoma. It's usually a photophobia, watering, and a haze, or because of the corneal edema, and of course there will be blepharospasm because of photophobia. In children, IOP rise can expand the cornea, and that's why the cornea is big. But quite a bit can be achieved with an office exam, and intraocular pressure. I insist on a GA in a child who is pre-verbal, because any amount of sedation, the moment the paracaine goes in, the child wakes up and starts squeezing the lids. The only way you can get the IOP numbered is to get your resident to do it, who is forced to give you a number. I don't believe that. A reasonable slit lamp examination, however, is possible using this so-called flying baby technique, where you got the baby wrapped with arms and legs all nicely tucked in so that they can't flay it around and fall down. I have two people, not one like this. One person holds a baby sort of prone, and the head can be hyperextended, and you can use a slit lamp and examine the anterior segment. What do we look for in the anterior segment? Cornea, of course, edema, Habs posterior embrytoxon, other iris anomalies may be there, axonfil rigor, aniridia, problems with the lens. As far as glaucoma is concerned, it's spherophakia and a subluxation. Rest is Leila Madam's problem. With a reasonable suspicion, we post the child for an EUA, and if there's a reasonable suspicion that this is a glaucoma, we post for an EUA with the consent to proceed to glaucoma surgery, unilaterally or bilaterally, so that we do not risk induction and recovery from GA, which is more dangerous as the very next week. So EUA, the first thing is always intraocular pressure. GA medicines do alter IOP, and low is expected with sevoflurane and nitrous. Higher is expected with ketamine, especially immediately after injection. So wait a little bit if you're using ketamine. And just after scoline, again, after some time, it does come down. So factor these in when you think about the intraocular pressure. And what is normal in an infant newborn? You're expecting 10 to 12. Anything higher, there should be a red flag. And by 7 years, the average is 14. So consider high teens as abnormal, and definitely operate if it is above 20. On the microscope, what we can use a handheld slit lamp also. What we're looking for is anterior segments findings like this Habs here. I think that's fairly obvious. There's a Habs going right across. And next, we look for the physical parameters of the eye itself, starting with, of course, the corneal diameter. And we record the white to white diameter, horizontal and vertical. Normal in a newborn is 9.5 to 10, and above 12 is considered abnormal. And at any age, as the child grows up, the corneal diameter also is expected to increase, but at any age, above 13 is considered abnormal. That's the white to white, and this particular child had 13.25, and that is a 4-month-old child. So that's abnormal. In primary congenital glaucoma, the scleral spur is not visible. In the normals, the iris would recess back, and the scleral spur should be visible. That's the primary thing you're looking for in gonioscopy. Also, the iris anterior edge as it inserts will be scalloped. You may have the wraparound or concave or convex. All three iris insertions are possible. And a lot of other findings like the morning mist, where it's hazy, where the iris root is. Loch Ness Monster sign is where you have loops of normal vessels popping in and popping out of the trap meshwork, etc. So I use a mirrored gonioscope because it's easier with our regular microscope, and that's a gonio going in, and you can see the scleral spur is not visible. Anterior edge of the iris is scalloped, and the trap meshwork is fairly featureless. That's your morning mist. Disc will be cupped, and it does reverse in children because most of it is due to the stretching. Use an indirect ophthalmoscope. Forget about all the designs and features of an adult glaucoma. You do not get them in congenital glaucoma, at least in the earlier stages. And a normal cup disc ratio again in children or infants is 0.1 to 0.2. So 0.5 can be considered big, and a bigger one is of course abnormal. And here, just to show the disc, I'm showing it through the gonio mirror, but we do assess the disc with an indirect. This is a large disc, but if you think of it as an adult, it does look like a healthy disc. But this is a large cup for a child. We also need to do refraction. Astigmatism and myopia need calculated corrections of the refraction numbers, and there is emmetropization by the flattened lens, in the sense that when we do an axial length, we expect this much for a myopia of this much, but that you don't get that because the lens is flattened out. Axial length again is recorded, and these are primarily recorded with an intent to follow up after treatment, because with IOP lowering, these numbers also come down. Management, primary is surgery often. Trabeculotomy is what I prefer as a first step. Goniotomy can include the new suture gap, and trabeculotomy with the trabeculectomy is also done quite often. In follow-up office visits, we observe the child's behavior to assess vision. We ask the parents historically how the child is performing, as well as look for amblyopia. Also assess possible need for further surgery and follow-up EUAs, such as corneal haze, enlarging cornea, etc. And on follow-up EUAs, I do my first follow-up EUA after a surgery at 3 weeks with the intent of taking out sutures as well, because any paracensis in an infant needs a suture. It's not like an adult. It's too elastic, it'll stay open. If okay, then we go on to an EUA at 3 months. If okay, 6 monthly till the child allows applanation. Usually most kids allow applanation by 3 years of age, but I do have spoiled children who need EUAs even at 12 years of age. I'll skip this. Thank you.